Hello and welcome to the March 2022 edition of the IMV Imaging Journal Club. This month we have looked at the equine research, and the paper that we have chosen is entitled Comparison of Ultrasonography and Radiography with Arthroscopy for the Diagnosis of Dorsoproximal Osteochondral Fragmentation of the Proximal Phalanx in 56 Thoroughbred Racehorses. This article has been recently accepted by the Equine Veterinary Journal, or EVJ, and it was done by two authors who are based in Ocala, Florida. As a bit of a background into this topic, fragmentation of the dorsal proximal aspect of the proximal phalanx, which is commonly referred to as P1, or the first phalanx, is relatively common in thoroughbred racehorses. And it is thought that this may be as a result of repetitive overextension of the fetlock joint. Now, with regard to distribution, this occurs predominantly in the forelimbs, about 90% of cases in the forelimbs in comparison to that in the hindlimbs. And it tends to be on the dorsomedial more than the dorsolateral aspects. And so when we consider the relative forelimb and medial versus lateral distribution, this is likely as a result of the weight and force distribution in these horses. And so it can be thought that this probably supports the etiopathogenesis as being repetitive overextension and athletic trauma. Lameness and the presence of distension of the joint capsule can be quite variable among cases. Traditionally, the diagnosis was done via radiography. Of course, radiography having thought to have predominantly looking at the osseous tissues. However, it has been identified that this technique or modality has a relatively poor sensitivity for these lesions. In converseness, ultrasonography actually has quite a good sensitivity for these lesions. There was a study done in 2009 which did use anesthetized horses, and so the images acquired were in the non-weight bearing limb, and in some of the cases the joint was distended with saline. But in these horses, ultrasonography had an excellent agreement with arthroscopy, which was used as the gold standard, and that is with regards to both the identification of these fragments but also the determination of their exact location, and the sensitivity was 96%. In this study, this was compared with a comparative sensitivity of 44% for X-rays. There were two hypotheses made by these authors. Firstly, that ultrasonographic examination would be extremely sensitive and specific for detection of dorsoproximal fragmentation of the first phalanx. The gold standard that they used for comparison was arthroscopy. Secondly, that ultrasonography would have superior sensitivity when compared with radiography. Looking into the study design, this was a retrospective study which included racehorses which were in training with a history of fetlock arthroscopy between 2016 and 2020, so a 4-year period. Their inclusion criteria is that the horses must have had arthroscopy for removal of a fragment from the dorsoproximal aspect of the proximal phalanx, or P1, but also they should have had a full series of radiographs taken of the affected joint, which were deemed to be of adequate diagnostic quality, and also they must have had ultrasonographic images acquired of the fetlocks. With regard to radiography, their standard protocol included what we would consider the standard views of lateromedial, dorsopalmar, and the dorsolateral and dorsomedial oblique views, but also a flexed dorsopalmar and a flexed lateromedial view. These images were reviewed blindly by 3 different clinicians: a surgeon, a sports medicine specialist, and an experienced clinician. So they all had varying experiences of interpretation of radiographs, but none of them were imaging specialists. The presence of a fragment was graded as either normal or non-existent, as suggestive, which was given a grading of 1, or definitive, which was grade 2, but also the location of the fragments. And so this could be categorized as on the dorsomedial aspect, the dorsolateral aspect, or indeterminate. With regards to ultrasonography, the images that had been required previously were blindly reviewed by 3 separate observers. 2 were thought to be experienced and 1 was less experienced. All images were acquired using the same equipment. It was a 12 megahertz linear array transducer using a GE Logic E machine and also using a standoff pad. In their protocols, the hospitals used, they did acquire both standing and non-weight bearing images. However, only the standing images were included for evaluation in this study. Images were acquired in both the transverse and longitudinal planes, and the presence of fragmentation was recorded as normal or non-existent, as having fragments, or as non-diagnostic. Again, the location was determined to be dorsomedial, dorsolateral, or other. I'm not sure exactly what other was. This was not an option that was available for grading of location in radiography, and this isn't detailed further in this study. The presence of fragmentation was defined as an irregular hyperechoic interface with or without displacement. The gold standard for comparison was arthroscopy. So the presence and the location of fragments were determined from the surgical report. Looking at the data analysis, they did do a priori power calculation, which used previously published sensitivity values, and this told them that they needed to have 35 sites or fetlocks with a minimum of 9 having biaxial fragmentation. So that is fragmentation on both the dorsomedial and dorsolateral aspects. Inter-observer agreement or repeatability was calculated between the reviewers using kappa statistics. And because each of the 3 reviewers gave potentially different gradings, going forward for the statistical analysis, the median value was used. With regard to the radiographic results, both grade 1 and grade 2s were analysed both separately and also as a combined entity. Ultrasonographic planes, longitudinal and transverse, were analysed separately and not combined. The sensitivity was calculated relative to the arthroscopic findings, so that would be the gold standard. They've calculated this both irrespective and respective of location. They also attempted to calculate the specificity, but what they did is they used the uniaxially affected fetlocks. So the control was actually the unaffected side of one of the affected fetlocks. So they didn't use either control horses nor control fetlocks, and I don't think that this was necessarily appropriate in the calculation of specificity. As such, during this overview of this paper, I have not reported specificity for this very reason. Looking forward to the results, 56 horses, so a total of 81 fetlock joints, met the inclusion criteria. So this was more than enough according to the power calculation. It was reported that most presented following speed work at some point, and mild or moderate joint distension was present in all horses. However, there were no specific numbers with regards to these two bits of data. All of the horses were reported to be positive to joint flexion. However, we didn't have any details with regards to who observed this positive response, who and how the fetlocks were flexed, and for how long. And so I don't think these results were necessarily comparative between the horses. Lameness was variable from no lameness to grade 3 out of 5. This was reported to be reported based on the AAEP scale. However, we didn't receive any details as to how these horses were evaluated when it came to lameness evaluation. It is possible that it was just a subjective ordinal scale on the scale of 0 to 5 if these horses weren't evaluated under the specific conditions as laid out by the AAEP scale. All of the fetlocks were front fetlocks, so metacarpophalangeal joints. The majority had uniaxial lesions, 78%, and 22% had biaxial lesions. 84% were located on the dorsomedial aspect in the right forelimbs, and 95% were located medially in the left forelimbs. Looking into the results of the inter-observer agreement or repeatability, considering radiography, the agreement was 0.65 when considering both the presence of fragmentation as well as the location. Now, when it comes to kappa statistics, a kappa value of 0 indicates chance agreement, whereas a kappa value of -1 is perfect disagreement, and 1 would indicate perfect agreement. And so a kappa value of 0.65 is a good agreement. There was much better agreement for discrete lesions, so that was grade 1 lesions, the kappa rose to 0.72, versus suggested lesions, which only had a moderate agreement of 0.56. There was also better agreement for the presence only, so that's the presence of fragmentation, irrespective of whether the location was accurately described using radiography. Again, the kappa was 0.72. With regards to ultrasonography, transverse planes for localization of pathology, so that is not only the presence of fragmentation, but correctly identifying the location, the kappa was excellent at 0.92. And when considering the presence of fragmentation, irrespective of exactly where it is, the kappa was almost perfect at 0.95. Considering longitudinal planes for localized pathology, the kappa was 0.64, so that has been lowered to good agreement, and for the presence only, 0.77, which again falls into the good category. Looking at the results for radiography, 63% of fetlocks which had dorsoproximal fragmentation had a radiographic pathology which was indicative of this, but this was considering both grade 1 and grade 2 results combined. So not only those which had definitive, very obvious fragmentation, but those with a suspicious pathology that wasn't necessarily definitely going to be a fragment. So of these horses, only actually 16% were graded as grade 2. So those horses which definitely had a fragment identified on radiography, which really is quite low. And just under half of these horses had suggested pathology in the region of the fragment, but not necessarily having a discrete fragment. So combining these two groups together certainly does increase the sensitivity of the test, but it does lead to a potential increased risk of false positives. Now, the rate of false positives using the grade 1 and grade 2 combined technique was not able to be tested in this study population because they didn't use any control horses or control fetlocks. So at the moment, we don't have this value, but there certainly is a potential for false positives. And as we know, the sensitivity is only a maximum of 63% for both grades combined. There is a relatively high chance or reasonable chance of false negatives. With regards to location, only 11% of lesions were correctly identified when considering just the grade 2 lesions. And further, 47% of lesion locations were correctly identified when considering both grade 1 and grade 2 lesions combined. Note that there are only actually two choices with regards to lesion location, either dorsomedial or dorsolateral, so this appears to probably be less than chance agreement. With regards to ultrasonography, in the sagittal plane, 88% of fragments were correctly identified, and of all of these lesions, 80% of these fragments were also correctly identified with regards to their location. So sagittal plane ultrasonography was statistically significantly more sensitive than radiography. When considering the transverse plane, 93% of fragments were not only identified correctly, but also the location was correctly identified in those too. This modality, transverse ultrasonography in particular, was more sensitive for the presence of P1 fragmentation than both radiography, but also sagittal plane ultrasonography. Moving on to the discussion. If we were to revisit the hypotheses, these were not revisited and discussed in the discussion in this paper, but I have revisited them at this stage. The first hypothesis was partially proven. So ultrasonography does appear to be highly sensitive for the detection of these dorsal-proximal fragmentations. However, as I've previously mentioned, they didn't have the case population of the cohort to accurately determine the specificity, and so they did not prove this hypothesis. With regards to the second hypothesis, ultrasonography did have significantly superior sensitivity when compared with radiography. Further, they did actually show that transverse plane ultrasonography in particular was more sensitive than sagittal plane ultrasonography. So they did prove that there was excellent ultrasonographic sensitivity, 93%. And this is actually in agreement with the previous study by Van der Perren et al. In 2009, which had a sensitivity of 96%. There was also agreement between these two studies for radiographic sensitivity. This was with regards to the presence and location of fragments, both with regards to definitive radiographic changes and also suspicious radiographic changes. And this was 47% in the current study, which is in agreement with Van der Perren's study, which was 44%. However, there was some disagreement. In the Van der Perren study, all fetlock joints had radiographic evidence of fragmentation identified. When considering this study, only 63% of fetlocks with fragmentation were correctly identified using radiography. This may have been contributed to by the fact that both of these study populations had selection bias. So in the current study, the selection process and inclusion criteria meant that the authors were selecting for less radiographically obvious lesions. This is because in this typical study population, identification of fragmentation prior to sending a horse for arthroscopy for removal is typically done, as they reported, radiographically. And so horses that underwent both radiography and further underwent ultrasonography were more likely to be those which had inconclusive radiographic findings. And so they probably selected against those horses with very obvious definitive lesions, which would be graded as grade 2. So this may have contributed to the relatively low sensitivity for the detection of fragments, irrespective of location. In the Van der Perren study, looking at the study design, it was unclear whether fragmentation, as seen on radiography, was in fact an inclusion criteria. It may have been that all those horses that were included had to have had a positive finding for fragmentation as seen on radiography, again, which would bias the sensitivity calculation. This does lead us to ask the question, would additional radiographic views increase the radiographic sensitivity? It certainly is possible, but this has not been reported in any literature yet. It also should be noted when discussing particularly racehorses that these extra views would not normally be included in sales or auction protocols, and so perhaps there's not a drive to look into this. Looking into this further, in the Van der Perren study, all of their 48 joints in that study had suspicious or confirmed radiographic changes, and this was based on the standard 4 projections, so lateromedial, dorsopalmar, or dorsoplantar, and the dorsolateral and dorsomedial oblique projections. Less than half, or 44%, agreement there was for presence and location. What this tells us is that all horses with fragmentation had been identified correctly on radiography. However, it was the localization of these fragments that was really letting the sensitivity down. And so this is likely as a result of the lack of visibility on oblique projections. They also reported that the most common specific location was between the sagittal ridge and the epicondyle, usually the medial epicondyle. So this is relatively dorsally located, and so therefore extra oblique views, perhaps steeper oblique views, to skyline the different aspects of the dorsomedial and potentially dorsolateral aspects of the proximal phalanx may well help in the localization of these fragments. It may well be that a 45-degree dorsomedial or dorsolateral oblique simply does not skyline the exact region of these types of pathologies. Another question that I think is worth exploring is the clinical relevance of these lesions. In this current study, all of the fragments had been removed arthroscopically, but is this really necessary for performance? Potentially when discussing this in racehorse terms or other sports horse terms, we know that these lesions do occur in racehorses or thoroughbreds, but they can also occur in other horses. For example, the Van der Perren study reported of these lesions in warm blood horses. Generally speaking, if they are associated with recurrent or non-resolving lameness, if they are particularly large, or if they have an irregular appearance, then yes, removal probably is indicated. However, we do recognize that some fragments are identified completely incidentally in horses in full athletic function without any clinical signs. And so potentially fragmentation, if it is small, smoothly demarcated, for example, these frequently resolve with rest if they were ever significant in the first place. However, it must be noted that some of these cases may be recurrent. It's worth noting the different potential etiopathogenesis of these lesions in racehorses versus warm bloods. Whereas racehorses, this may be as a result of athletic type trauma or an overextension of the fetlock joint during fast work. In warm blood horses, it has been hypothesized that this is potentially a manifestation of osteochondrosis type lesions, again, which may occur in otherwise perfectly fine and lameness-free horses. There are some significant limitations of this study. With regards to specificity and agreement, as I've already discussed, the specificity, although it was reported in this, was in fact not determined in this study, and nor has it been determined in previous studies. Further, no existing statistical analysis of any agreement between these tested modalities and the gold standard have been performed. And so to determine the diagnostic accuracy of these two modalities, radiography and ultrasonography, when it comes to detection of these lesions, we are missing some crucial information. With regards to the inter-observer agreement, the inter-observer agreement they used still ultrasound images only. This isn't a true reflection of how this modality is used in practice. And whilst it calculated the ability of different users to assess a previously acquired ultrasonographic image, it didn't assess the ability for users of ultrasound to be repeatable when doing this in a normal practice setting. There was high agreement between the less and the two more experienced observers. But again, this was based upon prior acquisition, and we don't in fact know who or the proficiency of the person or people who acquired these images. There was also, again, a degree of selection bias. In this study, there was probably selection bias against radiographically obvious lesions. So we had fewer grade 2 lesions and potentially a higher proportion of grade 1 lesions, or those with suspected pathology. So this is not necessarily reflective of the general population of racehorses. With regards to the clinical applications of the findings of this study, ultrasonography certainly seems to be highly sensitive for the identification of dorsoproximal fragmentation of the proximal phalanx, and certainly has been recognized in several other joints that ultrasonography is a very good modality for assessment of marginal pathology of joints. Particularly, it is the transverse plane images that appeared to have the highest sensitivity with regards to identification of these lesions in comparison to sagittal plane ultrasonography. So again, highlights the importance of always acquiring two orthogonal views. There was excellent agreement between ultrasonography and arthroscopy. And the sensitivity of radiography, in general, probably it was underestimated in this study and may not be in agreement with previous literature. And so suspicious radiological findings may well be indicative of fragmentation, but we don't know how many of these may represent false positive results. And so this comes back to the fact that ultrasonography is probably a very useful modality to either confirm the presence of fragmentation or refute those findings. There certainly is scope for further studies to be performed in this area of research. Certainly, we do need to have determined the specificity and agreement with the gold standard in order to more definitively define how good are these two modalities when it comes to diagnostic accuracy. We certainly need a larger study which involved control horses or control fetlock joints, and this would be more representative of the general population with less selection bias. Thank you very much for joining us for this edition of the IMV Imaging Journal Club. If you do have any questions, then please do not hesitate to get in contact with us. Equally, if you have any comments on this. The email address for contact is clinical@imv-imaging.com. Please also feel free to view our website and contact us via there. Thank you again.